Once again, I want to thank the opportunity to be here in Phoenix, and let me congratulate you all here in the room that you're still, late in the afternoon, and you're still sticking around. That's very good to see you here. So let's talk about fibrinogen. So maybe after today, you're going to go home, and you're going to think that every trauma patient that has a massive bleeding will get plasma. And I'll tell you, that's incorrect. In fact, not every patient who has a massive bleeding will get plasma as part of the resuscitation, but there's, particularly in Europe, there's a tendency to use fibrinogen instead. It's not add fibrinogen, it's fibrinogen instead of plasma. Are they right? Or are we right? So let's talk a little bit about fibrinogen and its role in patients with massive bleeding. Okay, if I can make it move. Which one? Sorry, this one. The right one. Oh, this works better. Yes. Okay, works better if we got the right one. So, I have a disclosure. I have been part of the CSI Behring Scientific Advisory Board, who is working on fibrinogen concentrate. So let's talk a few things that I think are key here. So one of the big advances in the present century, in the 21st century, was understanding early coagulopathy of trauma. So we always knew that trauma patients didn't clot well. But until the beginning of this century, we thought that this coagulopathy was something that you acquire over time. So patients were bleeding, they were losing platelets, they were losing clotting factors, they were being diluted, they were being cooled, and that's why they became coagulopathic. Until 2003, when there was a paper by Brohi that changed completely. What Brohi showed in his paper was this coagulopathy occurs immediately after the trauma. And it's independent of dilution, independent of hypothermia. A trauma patient, immediately after the trauma, 1 out of 4 patients can't clot appropriately. It's part of our response to trauma that you have a failure of your hemostatic response and you don't clot well. And what we have learned since 2003 is that there is a release of an anticoagulant called activated protein C, and there's a release of a fibrinolytic agent called TPA after trauma. And those are the ones responsible for the early anticoagulation of trauma. Okay? So that's a big advance that happened in the early 21st century. Another advance that happened in the 21st century, and I'll bring it to you again, is not every coagulopathy is the same in trauma patients. So let me just ask you, who's familiar with TAG and ROTEM here in the room? Who has seen TAG ROTEM? Okay, not many. So TAG and ROTEM are a machine that measures the whole coagulation. I'm going to show a few pictures about it. So this is a study we did with about 600 trauma patients. They are all bleeding. They're all bleeding. But 1/3 of the patients had a normal clotting. So here, this curve here, they show how strong the clot is. Let me show here on this other side. Shows here. 1/3 of the bleeding patients are not coagulopathic at all. They are bleeding because they have a hole in the aorta. If I make a hole in the aorta, doesn't matter how good you can clot, you're not going to stop bleeding. So 1/3 of the patients have what we call mechanical bleed. 1/3 of the patients here are hypocoagulable. Look at what a weak clot they have. Only 1/3 of the patients that are bleeding. In Brohi's study, he said that 1 in 4 were bleeding. In our study, we saw 1 in 3 couldn't clot well. And then 1/3 of the patients are actually overclotting. Hypercoagulable. How's that possible? 1/3 of the patients. Imagine if to this patient here, you give them plasma or fibrinogen, if you're doing this patient a service or not. And actually, a small number of patients have something they call hyperfibrinolytic state. It means they form a clot and they dissolve it very quickly. They form another clot and they dissolve it quickly. And this is, on the studies using TAG ROTEM, only 3 to 6% of the patients. So one thing that we know now is that early coagulopathy of trauma is inherent to trauma. Has nothing to do with dilution, or dilution will make it worse. but it's not caused by dilution. And it's release of an anticoagulant and a fibrinolytic, and not every trauma has the same coagulopathy. So how do we treat patients today that are massively bleeding? So if you're in North America, if you're in the United States or in Canada, what you're going to do is what you have heard the whole day today. It's called damage control. Basically, you give plasma to these patients. It's a blood-based resuscitation. You give these patients lots and lots and lots of plasma. That's what you do while you're trying to stop the bleeding. But as I said, if you live in Europe, maybe my colleague Dr. Luke Lennon can confirm that. Maybe I don't know if in Holland they do that, but they don't give plasma there. They give fibrinogen. Does that make sense? Are we wrong? Are they wrong? Are we all wrong? Oh, okay, let's see. Let's talk a little bit about fibrinogen. So what is fibrinogen to start with? So fibrinogen is a clotting protein that's produced in the liver. Some people say, especially the Europeans, that is the most important protein in coagulation because it's at the end of coagulation. So what happens is the whole coagulation cascade forms thrombin, and then thrombin moves insoluble fibrinogen to soluble fibrin. And then this fibrin basically attached with the platelets and forms a clot. So actually, if you get a chest tube, I'm going to exaggerate a little bit, and you put fibrin and clot and shake, fibrin and platelets, and you shake, you're going to get a clot. That's all you need. Okay? So there's some evidence that actually if you have low level of fibrinogen, actually you don't form a good clot and you bleed more. There are two ways to replace fibrinogen. Either you give cryoprecipitate or you give fibrinogen concentrate, and that's a symbol for concentrate in here. Every time you're going to read anything about fibrinogen, the first thing you're going to read is that fibrinogen is the first clotting element to drop. And everybody refers to a paper who's almost 20 years old called Hipala. And by the way, do you think he was American or he was European? Guess. If I was talking about fibrinogen, he was European, right? So this paper, who's 15 years old, said that fibrinogen is the first element to drop if you're bleeding. I'm not sure. I think he's right, but I'm not absolutely sure. And the reason is because we did a study in my hospital, approximately 100 patients, and we saw that the coagulopathic patients do have low fibrinogen in the first hour after trauma. That's true. But notice, not every patient has low fibrinogen. Some patients don't have low fibrinogen. But I found out in our study, 105 patients, that actually factor 5 seem to be lower before fibrinogen or about the same time. But seem to be. So for now, believe what everybody says. Everybody refers Hipala and says that fibrinogen is the first clotting element to drop. Why does fibrinogen drop in trauma? Why does that happen? There are many reasons for that. So acidosis. So we know that acidosis affects clotting. That's well known. So there are some studies in swine that show that if you increase acidosis, if you drop the pH of the blood, you increase the breakdown of fibrinogen almost 2 times. So that's one reason. Trauma patients are acidotic. So they start breaking down their fibrinogen. Another thing is hypothermia. There are studies that also show that as you cool down, so these are beautiful studies by Martini in San Antonio, that she showed that as soon as she started cooling down the swines, the synthesis of fibrinogen drops. So 2 reasons why fibrinogen drops after trauma. And then there's our help too. Every time you give crystalloids and so on, you dilute the fibrinogen on the blood, and there you go, it goes down again. And if you're European and you use colloids to resuscitate, you're also going to influence the polymerization of fibrinogen. And finally, remember that I told you there are 2 things that happen early in coagulopathy. You release an anticoagulant called activate protein C, and you release a fibrinolytic called TPA. So actually, there's also a breakdown of the clot that you form, and the clot is fibrin, right? It's fibrin and platelets. So another reason why fibrinogen falls in trauma is because there's hyperfibrinolysis. And this is another study of ours. Here's the normal levels of TPA, and here are some of our patients. Look, in the first 3 hours, there's a massive release of TPA. And coincidence or not, tranexamic acid, who's an antifibrinolytic, only works in the first 3 hours. Look at that. And TPA is only high in the first 3 hours. But what's more interesting here is that remember that I told you that ROTEM identifies a hyperfibrinolytic state in only 3-4% of the patients. But if you measure TPA, about 50-60% of the patients bleeding have high TPA. So I think that blood test is not a perfect test, probably only diagnose the extremes of fibrinolysis. So, okay, so now you know that fibrinogen is very important in coagulation. You know that it's low in trauma patients, and you know why. Right? So let's keep on moving. How about if I give fibrinogen back? Does that make any difference? Actually, there are some experimental models that say yes, if you give animals fibrinogen concentrate, they decrease their bleed. There's actually a lot of studies in general surgery, gynae, neurosurgery, cardiac surgery, blah, 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 that if your fibrinogen level is low, and I give my cardiac surgery fibrinogen, they reduce their bleedings. And actually, there are many recommendations, right? There's even the traditional recommendations that if your fibrinogen level is below 1 gram, you should give fibrinogen. And actually, the most recent European guidelines for resuscitation of trauma patients say that you should go higher. In fact, you should use 1.5 as your level to replace. And then we had a colleague of mine, Dr. Nascimento, who did his master's degree, and he showed that every time you give 1 unit of cryo, you bump up your fibrinogen level by 0.06. And there's one study, actually American, that showed that it was Stinger and Spinella, that in 252 soldiers in the Iraq war, actually fibrinogen was the most important point to make them stop bleeding. Actually, the amount of fibrinogen given to the soldiers was a direct link to survival of these patients. And there are other studies on ROTEM, all peri-op, showing that if you give fibrinogen concentrate, you decrease bleeding and transfusion. And actually, there's some recommendations. This is another work that we're doing. We're trying to find thresholds for use of blood products, and we find out that if you have a ROTEM and you use the amplitude at 5 minutes, if it's below 7, means that your level of fibrinogen is very low. Better start giving fibrinogen. Okay? There's actually a systematic review, and this systematic review was published in Critical Care, and this systematic review is mostly done by Europeans, and they compared plasma and fibrinogen. Actually, there's one American in this study, it's Dr. Haas from Baltimore. And this was a systematic review. They got all the papers that exist on use of fibrinogen and use of plasma to resuscitate big bleeds. But again, they mixture operative bleed and trauma bleed. So you see, it's not just trauma there, right? And what they found out was actually the evidence supporting plasma use is inconsistent at best. And actually, that's what they wrote there, that the evidence that plasma decreased mortality in trauma or in massive bleeds is actually very, very limited. It's not good at all. And then what they concluded, actually, on the other hand, fibrinogen not. All the papers on this systematic review shows that fibrinogen, if you give fibrinogen to someone that's bleeding, they will reduce bleeding. They will reduce need for blood transfusion. But the point is, there's not a single study on fibrinogen in trauma. You happy? Should we use fibrinogen? I'm not convinced. So, and that's the problem. The problem is we're at a time where the evidence is not that great. The evidence supporting what we do here in North America, the evidence they do in Europe, is not that great. It's hard to actually know what to do. So I'll come to my first conclusion, and then we'll go for the second part of my talk that's brief. So you know this. You know that coagulation depends on fibrinogen. You need fibrinogen to have a clot. And in fact, fibrinogen is the primary substrate for coagulation. And there's actually a lot of patients that you're treating that are coming to you and they have critically low levels of fibrinogen. And if you don't measure, you're not going to know it. And part of the problem they have that they are not clotting is because their fibrinogen is very low. And actually, there's one study from 15 years ago who says that fibrinogen is the first clotting element to drop, much before clotting factors, much before platelet, much before anything. Okay? You also review now with me that dilution with fluids, acidosis, hypothermia, and fibrinolysis all deplete fibrinogen even further, and that's why trauma patients, not only they arrive with low fibrinogen, but it keeps on falling over time, fibrinogen. And there are some studies that say that maybe if you give fibrinogen back, maybe your patient will do better. Okay, so let's go here. And I'll end here with a clinical trial. That's actually, as far as I know, is the best study that I've seen on fibrinogen replacement. And no surprise, Brahe is involved on it too. So it's Rourke, Davenport's another one of my heroes in coagulation studies, Stanworth, Brahe, all Europeans. And they did a study on humans where they actually gave fibrinogen to trauma patients that were bleeding. And here, let me summarize the study for you. So this morning I had the privilege to show you some of my own studies, our own studies in Toronto. Now let me show some of the studies that were done by these two British hospitals. So this was a prospective cohort study involving more than 500 patients. So I take my hat there. All patients had to be included in the study, they needed a massive transfusion protocol. And what happened there in England, just like in Canada, we don't have plasma thawed in the emergency room. So when he did the ratios, he actually, to begin with, patients were getting red cells but no plasma, and he measured fibrinogen at 3 points. By the time they got 4 units of red cells, by the time they got 8 units of red cells, by the time they got 12 units of red cells. And by then, they had got some plasma and some plasma, a ratio of approximately 2:1. And they gave them cryo. And they gave a good amount of cryo, about 10 units of cryo and so on, at 4 units of red cell transfusion, at 8 units of red cell transfusion, and so on. And that's usually the commonest way that people replace fibrinogen, is by giving cryo. And they define coagulopathy as a ROTEM at 5 minutes below 35. And that, again, for me shows that ROTEM can be very useful, actually. ROTEM will identify the lack of fibrinogen, and in 5 minutes you can know that. So much faster than if you send fibrinogen to the lab and you wait for the result. What they found out was that 14% of the patients arrived with a low fibrinogen to start with. And also they noticed in their study that low fibrinogen was directly associated with hypotension, severity of shock, ISS, and need for fluid. So he showed what we all know. Fibrinogen is an important coagulation, and if you don't coagulating well, you're hypotensive, you're bleeding, your ISS is higher, and so on. Okay? And they also showed that there was a good correlation between ROTEM at 5 minutes and the regular way to measure fibrinogen in the lab. So we know this, right? We talked about this before. We know there are lots of patients arrive with low fibrinogen, and all these patients are going to be in shock usually. They're bleeding and so on. They can't clot. But that's the interesting part of their study. They gave supplemental fibrinogen, and to the patients they gave supplement fibrinogen, they were able to maintain their fibrinogen levels within acceptable levels. While the patients who did not get supplemental fibrinogen, the fibrinogen kept on dropping. So they showed that if you give fibrinogen to bleeding trauma patients, you actually can maintain their fibrinogen level within acceptable levels. But the problem is, did it change mortality? Guess. Did give fibrinogen change mortality? No. So that's, again, an interesting study, because patients who survived had higher fibrinogen levels. But the fact that you replace fibrinogen did not mean that the patient would survive more. Looks like they were going that way, looks like there's a wave towards that way, but there was no proof. So in the end, what the study showed is that fibrinogen levels are associated with mortality. However, if you supplement fibrinogen, they couldn't show that there was a mortality benefit. Maybe it's the limitation of the study. So, or maybe fibrinogen is just a marker of gravity. I don't think so. I think there's a lot of evidence that fibrinogen is a key element actually in coagulation factor. So that's their conclusion. The trauma patient, many patients arrive coagulopathic, we know that, and many of these patients will arrive with a very, very, very low fibrinogen. And even if you use damage control resuscitation, even if you give this patient tons of plasma and platelets, you are not correcting fibrinogen. The fibrinogen will continue to drop, even if you keep on giving plasma and platelets. Okay? But if you give supplemental fibrinogen in the form of cryoprecipitate or fibrinogen, yes, you're going to correct this type of coagulopathy. You're going to correct the deficit of fibrinogen. And they suggest that if you do this, if you supplement fibrinogen, probably you're going to improve the survival of your patients as well too. And they also show that it's great to have a lab that can show you if the patient has a low fibrinogen and needs fibrinogen supplement or not. But their conclusion is the same one in every study to date. We need better studies. And I know they're already starting a newer study, basically, that's probably going to answer this question. So I'll finish here and go, here, great, now what? Now what do I do? So I'll give you my opinion, okay? And I'll take the consequences. So here's my opinion. So my opinion is, number one, not every trauma patient that's bleeding is bleeding because he or she is coagulopathic. And even if they are coagulopathic, there are different types of coagulopathy. You can have a patient who has only absolutely excessive fibrinolysis, and this patient needs tranexamic acid. On the other hand, you can have a patient who's bleeding but hypercoagulable, and this patient needs nothing. And you can have another patient who's hypocoagulable and will benefit from getting plasma and platelets. But not all trauma patient, not all coagulopathic patient has the same profile or needs the same treatment. So today, I hope that I have shown you that fibrinogen is an important one. In many of the patients who can't clot well, the problem is the fibrinogen. And if you don't measure, and if you don't correct the low fibrinogen, these patients are going to continue to bleed, and their chance of dying will continue to grow. But now if you ask me what's the best way to treat a patient, a trauma patient, in my personal opinion, is not giving plasma to everyone, is not giving fibrinogen to everyone, is actually diagnosing the problem, is actually custom-made resuscitation. Each patient is different. Each patient needs a diagnosis. You have to identify what's the problem and what they need, and you have to correct that quickly. The current lab tests are not good. They take too long. So that's why when we start resuscitating someone in my own hospital, we start blindly. Because I can't. I have someone bleeding to death in front of me. There's no lab that can help me now. I start giving everything I have. But then as quickly as possible, get the lab to help you. Because you may be giving plasma to a patient who needs fibrinogen, and you may be giving fibrinogen to a patient who needs tranexamic acid. Or you may be giving plasma, and this patient don't need 10 units of plasma. They need 40 units of plasma, and so on. And for me, one of the lab tests that can be helpful is actually ROTEM or TAG, and I like particularly ROTEM because at 5 minutes, I can tell if my patient needs especially fibrinogen or not. But if you don't measure, you don't know. And then, so in my opinion, the best treatment is custom-made for your own patient. So once again, it has been a privilege to be here in Phoenix. Thank you very much.